morning. I'm Dr. Menzler. I'm one of the orthopedic surgeons here at Phoenix Children's, and today I get the pleasure of introducing our grand round speaker. So Dr. Leah Brown is a board certified fellowship trained orthopedic surgeon specializing in sports medicine. She received her Bachelor of Science in Genetics from University of Georgia, where she was a 14-time NCAA All-American, a 2-time NCAA National Gymnastics Champion, and was inducted into the University of Georgia's Circle of Honor in 2016. She earned a Doctor of Medicine at The Ohio State University and the Cleveland Clinic Foundation on a full U.S. Navy Health Professional Scholarship, followed by a surgery internship at Navy Medical Center in San Diego. Dr. Brown completed residency at the Department of Orthopedic Surgery at Naval Medical Center in San Diego and subsequently joined the center's Department of Orthopedic Surgery as faculty orthopedic surgeon. She served our country for many years, including deployments in Iraq in support of Operation Iraqi Freedom and Afghanistan as part of Operation Enduring Freedom. She's a recipient of 9 military honors and awards, including the Bronze Star, Meritorious Service Medal, and Navy Commendation Medal. She continues her military service in the U.S. Navy Reserves and as orthopedic and director of clinical operations for NMRTC San Diego. Dr. Brown is fellowship trained in orthopedic surgery specialties, including sports medicine and shoulder and elbow, completing her fellowship at Ortho Carolina in Charlotte, North Carolina. She currently works at Banner University, where she continues to be head team orthopedic surgeon for the Phoenix Mercury and assistant team orthopedic surgeon for the Phoenix Suns. She continues to be a huge fan of her Georgia Bulldogs. She loves to cheer for them in her free time with her husband, John, and her twins, Eva and Wardell. I'm honored to now introduce my dear friend and orthopedic colleague, Dr. Leah Brown.
Good morning. Thank you for having me. It's such a pleasure to be here. It was interesting when I was trying to come up with something to speak about and thinking about the diverse crowd. Nobody's going to be, well, not maybe a few people in here would be really geeked out about some of the orthopedic stuff that I find so interesting. But I figured we would try to talk about something that really affects us all and we can all have an impact on. And I first tried to narrow it down kind of specifically for women, as that was kind of where my mind was going. And then I was thinking, this is not just a women's talk, this is a talk for everyone, because ultimately we are all the solutions to the issues that I'm going to bring up. And it's specifically about humanity and inclusion and how physicians should take back the leadership in the healthcare delivery system. We all know that we're struggling. I'm trying not to use the word failure. But a lot of times it feels that way. Just kind of a reminder, humanity, because sometimes what we do every day, we feel like there's a little loss of it at times. This is the oath that I took when I became a physician. So in all of those wonderful goals and promises that we make are becoming increasingly difficult. And, I want to make sure to emphasize that this talk is not meant to offend anyone or ostracize anyone, especially any other colleagues that really work hard to take care of our patients, because it takes a total team to do this. So much time and energy is wasted on an us versus them mentality, whether it's physicians, administration, nurses, advanced practice providers, techs. The real issue is how the business of medicine is overshadowing the purpose of medicine. And that is to maintain and restore health to those that need it by those experienced enough to do it. I've experienced medicine and delivery in a vast array of systems, whether that's the big university system, it's a big for-profit hospital system, military, austere environments, single specialty, large center, private demics, and we're all affected. So, we all talk about kind of the burdens that physicians face in our healthcare delivery system. And we talk about how we spend so much time in the electronic health record. And so much of that is just not productive time. The physician-patient relationship is really the core of medicine, and it's really being stressed by the business of medicine. So just kind of some factors that are really burdening to us. I mean, this is really what it feels like sometimes. You know, you've got the administrative burden, you've got limited time for patients, losing autonomy, you're trying to advocate for patients, there's shortages, there's moral distress, there are all these things that are just kind of impacting our ability to deliver healthcare the way that we want to do so. So I don't have to talk to you guys about the administrative burden. We feel it every day. You know, it's really talking about the documentation and all of these reporting requirements that we have to do, you know, to satisfy insurance regulations and government oversight and our reporting. This is really leading to limited time for patients as this administrative burden comes. You know, we struggle to provide comprehensive care, to listen to patients, to give them the time that they need to really make them better in a holistic way. We spend so much time trying to do other things. It's really hard, and the things that we really need to do are decreasing our quote productivity time, and we're kind of forced to do it in off hours time, which then has its other impacts. It feels like you're losing autonomy. You know, the healthcare decisions are being made by insurance organizations and hospital administrators and government regulations, and you know, sometimes you're feeling compelled to prioritize cost-saving things and meet other metrics, sometimes in spite of what you really believe is the best thing for your patient. And that leads us to have, you know, this patient advocacy role, and these are really not a part of our productivity measures. It's part of what we want to do and what we know we need to do. But how that affects us is that it really starts to bear a burden and cause a financial strain. And a lot of people that come out of medical school have a lot of debt. The practice of medicine is appealing, but then you see the financial burden that can come with this process. Sometimes it leads people to leave medicine or not pursue medicine in the way that they wanted to. So ultimately, this is having an impact on patient care. And the failures in our delivery system can cause delayed diagnosis. You're limiting treatment options. There's inadequate access to care, and ultimately, it's eroding patient trust in our healthcare system. I don't like to use the term burnout because it's really not fair. Although appropriate in some contexts, I really, really think that the term moral injury is a better description, because burnout implies that there's a problem with the individual, and we know that that's not really what it is. Moral injury is occurring due to exposure of continuous injurious events like PTSD and just the trauma of having to deal with all of these frustrations. Self-care is super important. Sometimes we don't do it. Physicians are harder on themselves than the average person. It leads, it's cultural, and it starts in medical school training and continues throughout the medical environment. And we really need to shift the culture in making sure we emphasize self-care and not make it feel punitive when we do require self-care. So all of these things are starting to feel like to manifest in physician shortages, especially in underserved areas, which then exacerbates the care disparities. Physicians are often overworked. It leads to increased workloads, longer hours, and diminished work-life balance. And this is creating an environment where we're not able to recruit and retain the best and the brightest. And we need to advocate for immediate solutions to our GME problem. So we have so many unmatched physicians, and there's nowhere for them to go. This is not an us against them, but MDs and DOs should not have fewer options than PAs and advanced practice nurses. But that's just our reality right now with the bottleneck in our limited GME positions. Proliferation of medical misinformation on social media, it's really causing some issues. Much of what we see is misleading and just downright false. And as users share this and reshare posts, myths and misconceptions can really spread quickly. And when patients come across this information and it contradicts what their physician says, it really can cause distrust. And this is really exacerbated if the patient feels that the physician is dismissing them. So this is kind of affecting decision making, and misinformation can lead patients to choose things that may not be the best for them. We also have to deal with direct to consumer marketing. You know, in countries like in the US, you actually have pharmaceutical companies advertising directly to patients. We see it every time we turn on the TV, every time, you know, we open up our computer, there's some ad saying that this medicine is going to cure this said disease, and ask your physician for it. So, you know, this often leads to skewed perceptions from the patient and how they can be cured. There's sometimes pressured prescribing because patients are pressuring physicians to do this, and physicians may believe another course of action is more appropriate. So would a better solution be to advocate for a better health literacy instead of direct advertising regarding the disease condition? So as all of this occurs, you get a broader distrust in the institutions, and it's fueled by divisive politics, which means that people are really skeptical of the medical community's advice, and they see it as potentially biased or part of larger conspiracy theories. And you just kind of get this vicious cycle. So, I mean, we can talk about all the legislative interference, all the regulations, all the insurance mandates. I mean, there's a ton of that. And then we start talking about other issues that are affecting the organization within. And so this is when we kind of start diving into the diversity and inclusion issues. And so it's not just about a matter of fairness or ethical impairment. It's really about health outcomes and physician well-being and overall success of the organization. So minority and women physicians are often exponentially affected by this, especially when it comes to underrepresented patients and both underrepresented patients and physicians. With its burdens, like the challenges of discrimination are excessive. So these are just some kind of additional factors that are even more burdensome for minority physicians and women physicians. So you have different expectations with patient loads. They're often more represented in underserved areas and dealing with more complex medical and social issues due to socioeconomic disparities. And they're often expected to bridge a cultural gap or a linguistic gap. And these barriers added just kind of an additional stress, but be it both professionally and emotionally. Specifically, we can talk about the economic challenges and the financial disparities. So research has repeatedly shown that minority and women physicians earn less than their non-minority counterparts. So, and that's even after controlling for factors like specialty, experience, and patient load. So imagine if you have a stress of coming out of medical school with even more debt for other issues, then you're not making as much money. This just exacerbates over time, and over a period of a career, you can never catch up. And this is really causing some secondary stresses. And you can see these graphics. It's pretty impressive, particularly on the, you can see how the disparities are consistent across the board. This can also lead to barriers in professional advancement. Specifically, this is a graph regarding a poll taken from African-American medical students, and they feel that they have fewer opportunities because mentorship may not be available, or they don't have access to an influential networks, which may limit their potential for their professional growth. And lack of representation in leadership positions further perpetuates this cycle, creating even more limitations among these populations. There's also research and funding disparities. Minority physicians are often pigeonholed into conducting health research into health disparities, and that they really are kind of forced into this position, and it can be limiting to their academic scope. And studies have shown repeatedly that minority and women researchers have been received significantly less grant approvals, which limit their contribution to science and potentially their career advancement. So all of this cumulative effect impacts wellness and can really push burnout in these members and women and minority physicians. So ultimately, addressing these disproportionate burdens is not just about equity, it's essential for the health of the entire system. So we talk about these problems. So, what are some of the solutions? Well, I mean, they seem to be pretty easy, but we haven't accomplished it yet. So we can talk about transparency and really creating an equal pay system. We can have targeted mentorship programs. We need to increase their representation in leadership. We need to broaden, the societal understanding of what inclusiveness actually means. And we really need to address accountability and actually have metrics that measure real accountability. So, and we just talk about how how diversity actually improves patient outcomes, because with a more diverse workforce, you're better equipped to address these cultural and social needs from a diverse population. When your organization mirrors your population, they just oftentimes do better and can relate better. So there are oftentimes some unique health needs of underrepresented groups, and this can actually help decrease disparities. We can focus more on research and innovation, but also importantly, this improves patient well-being and physician well-being and physician satisfaction, leading to retention of important faculty and leaders that need to be represented. So again, this is really talking about organizational and system success. It has been proved over and over that inclusive organizations are more attractive to top talent. And so it leads to better recruitment and retention. It shows that diverse organizations outperform the non-diverse organizations, and they can better identify potential risks, including medical errors, misdiagnoses, and patient dissatisfaction. And this is really because they can view it from a different lens. And when you have multiple perspectives, then you can better address problems. So again, I've talked about how improved representation reflecting the community results in a better in better outcomes for your organization. So, DEI, that's kind of what I'm talking about, has become a very politicized conversation, and it really should not be relegated to metrics that are inappropriate and outdated, like our Medicare matrix. I mean, it doesn't work that well. Efforts to improve diversity and representation often meet resistance, and understanding the reasons why this is happening is crucial to overcoming the obstacles so we can actually be more successful. So some of the reasons are people really fear change, and many people have just an inherent fear of change. And when the balance of their norm is disturbed, their sense of stability is disturbed. Some people just really don't understand what the DE&I goals are. And some believe like there's some zero-sum effect, and there's going to give preferential treatment to some groups over other groups. And this is a perceived threat that, the zero-sum mentality is just really counterproductive for the goals. There are also cultural beliefs and ideological beliefs that are just deep-rooted in prejudice. They just happens. There are significant concerns regarding meritocracy. And so there's this misconception that improving inclusivity is going to compromise merit-based decisions. And that has just been proven to not be the case. But there is a profound belief that this merit-based system is going to crumble. It also, there's also a belief that it can lead to complacency, and some believe that it can have economic repercussions. So, as we work to promote this, understanding the roots of resistance and actually addressing them and having the hard conversations is really important. So in order to improve this, so the way forward is we just have to add value to this discussion and keep having the discussion and keep being transparent about it. Our leadership should be transparent about their goals and explain why this is successful for everyone. So what can we do? Actionable items. So and I talk about expertise and training a lot because I think it's really important to highlight that as physicians, we are very, very well versed in a lot of different aspects in the healthcare delivery system. So much so that people actually try to tell us that we don't know what we're talking about. We do understand the administrative issues. We do understand the financial implications, but we also recognize that we have to prioritize the patient-centered model of what we're doing. We have certainly been trained long enough to be able to understand new ideas as well. So we have to continue to emphasize the physician-patient relationship as the core of what healthcare delivery is about and not just the bottom line. We have to continue to advocate for individualized treatment plans. Algorithms just don't work for everyone, and we're seeing some of the issues that's happening. We also have to be respectful of patient preferences and values, and sometimes, they wanted a holistic approach, and we can be open-minded to provide that. Physicians also need to be the drivers of quality improvement initiatives and to utilize data and research to enhance the process. Physicians are better at finding ways to avoid medical errors and improving patient safety, especially given that we are working in the environment. So we need to be present and advocate for ourselves. We need to be present when policy is made. Physicians, we advocate for patients, but we also need to advocate for ourselves and for the system and be involved in policy and reform. So we need to take the lead in making sure that there's fair reimbursement and that we're allocating resources appropriately. And overall, recognizing our well-being is important and not putting our well-being second, third, and last to everyone else's. We need to actually respect the work-life balance and refuel and refresh and do the things that make us better physicians ultimately in the long run. We don't have a problem with motivation. We definitely have proved that we can stay the course and work hard. So, I believe that this is important because I think physicians have been kind of pushed down the priority pipeline when it comes to leadership in positions. And I think that there's a real need for physicians to be present in the healthcare decision-making leadership at the healthcare leadership table. And, I think that we need to remember that there's a human component to medicine, and that should always be the focus. Medicine is not a hard science. There is an art to it. There's a human aspect to it, and we need to align with each other instead of battling each other for the RVU here and the patient there to really improve the system. And I think that if we do this, we should be able to drive better, significant change to our healthcare delivery system and not have the insurance industry and the politicians do it for us. I think it was interesting for me to kind of do this talk because I really am kind of frustrated in seeing how we are being left behind in the realm of leadership when it comes to decisions in our delivery of healthcare. And so I wanted to open it up and have kind of a discussion and not just speak at people because, it's interesting. I don't know if we actually talk about this enough amongst each other. We talk about it in our small groups, but do we talk about it in the professional setting where it really can make a difference, where where everybody needs to hear kind of our perspective on it. It's not just about how I can get my 0.4 RVU for this in my dictation so I can code this and get my productivity up. How, what are the things that we need to do to see better change? And one of the things that's really, really important to me is I really, I don't want to just speak on kind of the diversity aspect of it, because I think it's more than that. Because I think diversity oftentimes gets pigeonholed to a certain racial or gender demographic, and that's not what diversity is about. Diversity is really about a diversity of thought. You know, we need older opinions, we need experienced opinions, so that's age. You know, we need newer opinions to keep up with what is going on. Like I can't do social media. I don't understand it. It does not work. I'm not going to get my patients through social media. We need people like that. We need geographic representation. We need all of these things represented so we can better understand the gaps in care that we have. And so one of the things that I have talked about, because it particularly manifested in a conversation, I have to kind of be careful on how I say this, but there are marginalized communities that have made it to a certain point. And as we talked about the gaps in reimbursement and the gaps in salary over time, you know, there are also ways that people have been gaps, like research publications. And we were looking at a person for an award, and it was a woman amongst men in a very non-diverse specialty. I'm sure you could not imagine which one it is. But this person is phenomenal, a game-changing person. Like a lot of people know who this person is. And when it came to the metrics for this award, this person didn't meet the metrics. And it was she didn't meet some very hardcore metrics, and they were peer-reviewed publications. Well, they weren't publishing women back then. And that is not a metric that she can change. That does not negate the fact that she had incredible influence in our in our in our specialty at the time. She had a whole lot of other types of things: publications in magazines, interviews, advocacies, community service, all of these things. The mentoring that she did was immense. And there was, so this one metric that she can't change because society did not allow her to have this metric. How do we account for that? Because what was so frustrating is trying to advocate for this person, and somebody wanted just to tell me about metrics. Well, that's not fair. And we have to be honest about what is fair. And so instead of asking for people to consider it, how are we going to start accounting for these past injustices? Because she had to deal with barriers that none of the other people written up for this award had to bear. Is that not fair? Is that fair? Because, you know, that's not just kind of this one little extra point because, oh, she had to deal with this. She had obstacle after obstacle for decades. So how do we account for that? So I think that those are the discussions that we need to have. Honestly, they're hard discussions, but we need to have all kinds of representation in the room, because does it last forever? How do, you know, I'm a numbers person. Metrics are important. You can't just throw them all out, but you can't be subjective one time and then be objective the other time. I came across another statistic about how women don't get promoted in the same way. And so we talk about glass ceilings and broken rungs. I don't know if people have heard that. Has anybody heard of the broken rung phenomenon? So the broken rung phenomenon is really about how women fall behind early in career progression, like from just kind of like in medicine, the assistant professor to associate professor role. They fall behind early because they don't progress as quickly. And a lot of the voting, and this happens in the corporate world as well, which is where the term comes from. But as they're climbing the ladder, the rung is broken because they're rated poorly when it comes to potential. So, interesting statistic, higher performance ratings. So if you take a man and a woman at a kind of not entry level, but early in their career, it found that women are graded or judged based on what they have accomplished. Men are judged based on what potential they have. If you think about that, that's just unfair. It's unfair. And you can see how it skews the progression, right? So if a woman has had to already do more at the same point, then that's a failure. So that's the first broken rung. So you have people falling out of the pipeline, which then, of course, then there's the glass ceiling conversation that I think more people know about. So it's just, we have to be able to address these problems in multiple ways. So I thought those were some interesting things that I came across as I was trying to put together this topic. It's a lot. I have a lot more slides, but I wanted to put it out there for you guys. What are some things that you think we can do better, or just have a hard conversation about in addressing either, failures in our delivery, healthcare delivery, or how we progress people the right way?
Yeah, that's very helpful. I think just to show some of these various slides that address the differences in improvement. I know it's being a topic and I think the number as well. One thing I thought is to just do more of that. So in our organization, certainly we have our organization 55 years old. I was the first program chair ever in 55 years, 3 years ago. And I asked the president at the time, like, this is really cool. Like, we should tell everybody, oh my God, like, there's a female program chair, like, what a difference that makes to the meeting. And the president did not want to talk about it. And so what we did is we put together an abstract, and it's being presented in May, of all the program chairs of every committee of our organizations to see, like, what other committees don't have female, not have female chairs. How many female chairs? And it's interesting because I'm on the program committee still. The program committee itself was super thrilled about sending that information. So I think it's just this visibility. And I wonder if, like, just really showing people over and over again how to motivate, things like that. I don't know what your thoughts are on that type of, I guess, hammering it.
I think it is. And so this is where it's really important to hear from our male colleagues, because, I feel it's hard. As you see, my family is a little diverse here. And so I ask my husband all the time when I'm complaining about X, Y, or Z, or I present some statistic. And I was like, does it feel like I always am attacking like you, like personally? Like, are you taking this personally in my frustration? And he's like, so it wasn't no. But he was like, no, I don't take it personally. He was like, but I feel wrong about it. And he's like, I don't know what to do. I don't have a solution about it. And men don't like to not have solutions and kind of be definitive. It's like, okay, like, here's your X, Y, and Z problem. Let's fix it like this. And then just be done with it and not think about it. Because I mean, like, I wish I had that. Like, I perseverate over things. But like, hearing from our male colleagues, I think is important. Does it feel uncomfortable in that avoidance of the discomfort? Because I agree with you. I think we should shout it from the rooftops, because it's not about how bad we were. It's about recognizing, hey, this is an accomplishment. It did take this many years, but this is an accomplishment, and we don't need to hide behind what happened in the past. It's in the past. Let's learn from it. Let's see, what did we do different? Was it because no woman raised her hand to volunteer? So then we need to push women to say, hey, volunteer for this. Throw your name in the hat for this, because that also is part of the problem. So this is not just, like I said, it's not a us versus them. This is really a root cause analysis. And so, so that long-winded answer to your statement, but I agree with you. I think it's important for men to not be silent in this part, and address, help us address how we have the hard conversation.
I am a physician. I have a leadership position in these children, and I find that I want to kind of go back to the beginning of this, which is like sort of women in not women, physicians and leadership, particularly back that aspect of healthcare. And I found that, I don't know, 90% of the tasks I do make are things that I've been asked to do, or not things that I've been trained for, right? You go to medical school, you can be a doctor, you can be a pediatrician, but I'm doing work in HR, legal, risk, other aspects. And I think that I think oftentimes physicians are sometimes put in leadership positions where they don't necessarily have the skill set to do that. What in your mind are some, I mean, everything takes time, right? Getting an advanced degree in MBA sounds like a great idea, but when you mentioned all the other struggles that physicians have with time, it's not just as easy as a paycheck. So what are some ways that you think that institutions can better support physicians to be in leadership and be successful?
So I think the important thing to understand about physicians is that we know how to learn and we know how to use kind of evidence-based ideas to come to a solution. And I think that that's what we bring to leadership. I don't think we should be in HR at all. Please don't do that to me. But I think that instead of having physicians manage an HR problem or a risk management problem, I think physicians being on a board or a panel or being, in that kind of advisory capacity to bring awareness on how to approach the problem is where we have the advantage, I think, over some other people. But you're right. I mean, I think the hard part is as a physician, we're given a problem, we're asked to solve it, we expect a definitive answer, and sometimes that's just not it. Even when we explain that to our patients, sometimes that just doesn't happen. I think sometimes that can be it as well.
Can you repeat the question for this in one?
So Dr. Perko asked about if I had been following the anti-DEI policy issues in the American Academy of Dermatology, and they recently voted to keep them. I did from afar. I have several friends that are dermatologists, Black dermatologists, and for my own sanity, I read only a little bit just to kind of keep updated. But I think it talks about the problem that I was saying about the attitude around DE&I initiatives and understanding what the resistance is the only way to really move forward with it. The meritocracy issue, the zero sum, like if you take, if you want to include, that means you're excluding. We really have to kind of do a deep dive in who we are as a society to address those kind of root cause dynamics, because I think that that's really what it is. It's fear, a fear of change. It's fear of loss. And there's not a benefit to be seen by some people. But, and what was your thought?
Like the anti-DEI precedent, but massive not quite a bit of it, right?
It's become kind of the politicized bad word. And it's unfortunate that's where we are. I mean, we can come up with different names of different initiatives or different policies. Ultimately, if people don't like it, they can advocate in ways that are successful against it. And social media definitely can emphasize that. Is there a man? Oh, yes, thank you.
Yeah, I'll add to that. So we were able to bring Dr. Brown here on behalf of the Women's Surgical Collaborative. So I have to really commend PCH and Dr. Austin for the support he's given us and to bring the continued discussion of these issues. So thank you, Dr. Austin. Thank you, PCH. But I I want to take a little bit of shift on the questions, but I would like you to comment on how your experience has been as a female leader in a very non-diverse orthopedic group and becoming a team position. The teams like with Mercury and your involvement with the Suns, and how you've gone on to develop those type of leadership roles in comparing those type of positions in other teams are not often. There's very few women team positions, so I don't know if you could comment on that.
Well, interesting. That's why I'm in Phoenix. I was recruited to do the job. And what was very interesting was my being a woman had nothing to do with it. And it was kind of the first time I felt that way. And it was a really incredible feeling. Like I didn't have to wear a hat of representing something. It was, I met someone who met someone, and they said, you need to talk to this person, because if you're looking to kind of retire, I think this person would be a great person to come on after you. And I don't think this person knew who I was, but we met and we bonded, and it happened. And it was interesting because I think everyone was surprised when I was asked to do this. So I was brought in, and I was the Suns head team doc for a while before I had twins. And people were flabbergasted, like who, even the players, the front office was just like, okay, are the men gonna be okay with this? And you really have to have the conversation. And my Dr. Carter, I'll just say, and so Dr. Carter was like, I never really thought about a man not wanting to talk about his medical problems with her, because she's smart and she knows the answer. And he was just so pragmatic about it. And for the first time in my career, which is not that long ago, this was only 7 or 8 years ago or so, I felt that I didn't have to wear that hat. So I think that says a lot about it. I have been well received. I love working with the basketball teams. It's a lot of work. It's fun to represent in a way that is new. There are not many women that do it at all, but I think I'm happy to see that people aren't as shocked to see me, or at least they hide it better. And it's becoming a norm, because we have now women athletic trainers on the bench. We have women, we're starting to see diversity in all aspects. It's not like in underrepresented, like just whatever it is, there's just so much diversity. Age is another big thing. Like I don't think we talk about the age factor enough, because as we are having some folks retire and kind of the new crew coming in, there does seem to be a little bit of a gap there. So there's that part. Sometimes in the leadership roles, I feel I have been pigeonholed into doing a lot of diversity talks or doing women themed talks, especially at our society meetings. And, we really are trying to say, hey, I have a really great patellofemoral conversation. I can really do articular cartilage. But somebody has to do it, because the conversation has to happen. And I am comfortable enough when I want to be to have the hard conversation. So it just kind of comes with the territory. And so just like I am asking other people that may not look like me to kind of sit in a little discomfort so we can help solve a problem, I'm willing to contribute to that, as long as people do respect the fact that I sit in that uncomfortable position a lot. But it's fun. I like being a team doc.
And a couple of comments on the chat that I think are right up your alley. They're both, I think, from the same person. She says, one thing I took for granted as a physician in the military was equal pay for men and women. Pay was based on time and service and rank. Not so when I left the military and entered academic medicine. Enjoyed my time in the military as a physician because we took care of people from all over the world, which was refreshing and informative. I learned every day from people who came from different cultures and countries. So could you talk a little bit about maybe since you were in the military too, compare what you liked about the military and maybe ways that it could be incorporated in the civilian workforce.
I love transparency. Transparency makes things so easy. And so when you meet time metrics and you meet promotion metrics, that's kind of what it is. And I love that. I love not having to think about productivity in a way that we have to think of productivity here. It was clean. It was just much easier. Unfortunately, military medicine is mirroring this medicine as well, and kind of some of the transformations that DHA has caused. But I wholly agree with that. And it's freeing, and it's why some people stay in military medicine, because it's not the pay. I'll tell you that. It's definitely not the pay. But it's transparent, and it's predictable. My absolute favorite place to practice medicine was in Iraq and Afghanistan, because it was pure. I was there to do a job. I wrote my scribble note. I documented it somewhere. I communicated. We all worked as a team. Like it was beautiful. It was literally everything in the oath that I had pledged. And even though it was dangerous and heartbreaking, I felt it was medicine at its purest. And I do think it's something that I wish we could all experience at one time, in a way that's not tragic and people are dying. It's unfortunate that that's kind of the way that it had to be, but I was really rejuvenated in life in a lot of ways as far as my decision in my career, because I really found that I was doing what I loved for the reason that I loved it. I just hated why I had to do it.
And any suggestions on how that could be incorporated? I mean, the transparency and all that, I guess.
I mean, I don't think transparency is hard. I think it just has to be a decision and a commitment. And, there's a reason why it's not transparent. And if we actually say the reason why it's not transparent, then we get to the root of the problem. Let's say it. Let's say why we don't pay people the same way. They're not incentivized to. There's a reason that they don't, because they can get away with it and they can continue to get away with it. But it has to be like a unified demand that they do it, because I don't think, women and minorities are kind of the easy targets to see, but it probably affects, it's geographic, it's able-bodied. I mean, as far as people who are most burdened, disabled women are up there with Black women. I mean, tremendously burdened with some of these strategies. So I think transparency and having the hard question is it. I think that the financial aspect is part of the reason it's going to be hard to incorporate the way that we did military medicine. Would going to a one-payer system be the right thing? I don't know. It wasn't all roses and sunshine, but I definitely think at least starting with transparency will help.
You mentioned that sometimes the metrics are not valuing everything that people do, and that there's blind spots within that. How do you think we push to include more things as we're looking at promotion or leadership positions, such as advocacy or academic work or other things that aren't fitting like what's in current metrics?
We have to demand it. I think now, because we've tried to work around it a lot of times and just ask for people's consideration. I think you just have to have the hard conversation and reset the metrics and have accountability metrics for burdens that some people face that other people don't face. I mean, some of it is about your demographic, gender, but some of it's geographic. I mean, people raised in rural places that don't have access to things, their life is so different. Like, it's so different in a way that I couldn't imagine. I was speaking to someone who grew up on a farm in like somewhere in Wyoming, and there was just no, they were not close to anything, and their whole life was different. I mean, that's a challenge. That is definitely a challenge that I think should be considered. There's a concept of invisible work as well, and maybe we actually just give that a metric. What is the invisible work being done? Women are often more challenged with the burden of invisible work, and that's mentoring, it's creating culture, it's things that are hard to be tangible. Like as soon as you find someone who's underrepresented or a woman, their request for mentorship is significantly different than some of our other colleagues, and there is that need to try to provide that mentorship or that extra thing, so you help fix the system for the younger generation. But that's time and energy. I think we should make that a metric, is like the invisible work, and give that credit.
It's a little bit difficult for me to talk about, but probably one of the most vocal opponents to affirmative action was Clarence Thomas, and he was likely the beneficiary of it, as was I. But his argument was that his entire career he's been dogged by this asterisk. That the reason he was the second Black Supreme Court justice was because he was Black. And so I guess I just wonder, with some of these DEI initiatives, is there some downstream fallout for that, where perhaps people are viewed as maybe carrying some asterisk alongside their accomplishments, alongside their rank position?
I think that, to me, is actually easy to answer. The asterisk is there regardless if we have the DEI initiative or not. And so because the asterisk is there, that means we need the DE&I initiative, because it's about creating opportunity. And if we want to fix things, you've got to go to the foundation of the problem. You can't try to limit something up here before you fix the real root of the problem. And I don't think our society is quite there yet to want to address all of the roots of the real problem. And so we're having to be creative. Now, I think that there are better ways to do it, for sure. But I also think that there has to be an understanding amongst a group of people that may not live this reality, to understand that this is the obstacles, it's a different reality. And to be kind of gaslit into saying we're all the same, we've made such progress, there's not a thing anymore, we just need to eliminate that, that's not fair. We can call it anything else, we can reframe it, we can restructure it, we can modernize it, but it's a real burden. And Clarence Thomas is entitled to have his own feeling about it, and his the fact that he has an asterisk, but the fact that he looks the way he looks, in a lot of aspects he's going to have the asterisk anyway. And it's not whether you got there because of it, it's just an asterisk somewhere. But that's talking about the thing that we don't want to talk about. It's the root of the problem. I don't know, does that help?
No, I mean, I guess I think that there is, we talk about having a different conversation. I think it's easy to argue in favor of it, but I do think that there are other people there, I think that both some of the beneficiaries can be affected by it, in terms of how their accomplishments are viewed. And then secondly, I guess there is in some ways it's a zero sum game. There are so many leadership there. And so I think that oftentimes it's a misperception of what DEI is, right? That it's not trying to get somebody to leg up, but it's just trying to sort of cast the broader net. But I think that oftentimes it's misperceived as giving somebody else a leg up, thereby creating this potential playing field.
Right.
And
Yeah.
So but I think that really needs to be emphasized. And I think it oftentimes gets twisted around as being something other than that. And I think it oftentimes then also winds up getting packaged in with, affirmative action sorts of things where it might get the DEI is something that's very different, but oftentimes it gets misconstrued as just being
Right.
affirmative action impacted.
Right. I mean, I wholly agree with you, and that's why I keep trying to emphasize diversity of thought and perspective versus just an affirmative action. And, you know, the two aren't the same. That you can kind of talk about them in similar lights in some facets of it, but they're definitely not the same. I also think that it's important for people who are fearful of the conversation and don't like the conversation have to understand why. And I think if they understand why, you know, if it's just, I don't want it to change and it's not fair because it is negatively affecting me, then that's the problem. And they have to recognize that that is the problem thinking is I am losing opportunity, where they are not taking into consideration that some people never had the opportunity. And so we're just trying to spread opportunity more fairly, spread it, not give it, spread opportunity. And I think that's, you're right, we just have to keep talking about it the right way. But, you know, if someone has an asterisk, if someone thinks that I got here because someone let me in, then that's a whole different problem of thinking. I have a whole other talk about DE&I that is, if people think that I am a DEI success story, then they're thinking about DEI totally wrong. I am a DEI failure. I am a success in spite of the processes, because the processes tried to break me so many times down the way. And so we have to, like, those are the conversations that we have to have. So yay, I'm here. I'm so happy to be here. And there's so many advocates that I had that look all kinds of ways, but I'm here in spite of the system.
I really like to put that, because when you were saying that made me think, isn't that exactly what the whole voice club is? Like, that term is just like opening the doors, right? As opposed to having to use the things, having those doors being closed. And just like one other comment in your slides that was talking about the different specialties in medicine, and that disparity in pay is greatest in the cervical subspecialties, and that just thinking about what can we do differently. I know we're not all surgeons in here, but there are things that are, and that we're falling behind because of things like that, or we are behind, because that disparity is great. And like for our national meeting, you know, like craniofacial surgeons, I interviewed the fellowship with 50-50 females, and there was not a single speaker that was female at our national meeting last year, and there has never been a female president. And there is a lot of gender tension, and all the women that I interviewed with are not at the meeting. Like, they're getting weeded out because it's hard to keep fighting the fight, you know?
It's exhausting.
And so maybe it's something about looking at what other groups are doing better than us to catch up.
Question, I think one of the important things that you said was that the asterisk is there. Like speaking, I guess my question is how we overcome that asterisk, but I feel like you mentioned, it starts early on with training. Like, if you remember going to my med school advisor's office and them asking me how many times did I fail step one, and it's like I've never even taken step one, so never. And like constantly having to be kind of call attention to myself, or almost brag about the good deed I did, because I feel like it almost goes unnoticed so much that I feel like I may lose out on opportunity if I don't call attention to myself, but not calling too much attention to myself, and finding that perfect balance between notice that I did this so that I can get something, because I need to put something on my CV so I can move forward in my career. So how do you, I guess, like, navigate that? How do you move yourself up when you feel like your asterisk is kind of, you're hiding behind this hard asterisk?
I think it's having the hard conversations, and just like, I don't know your name, sorry, but just like you discussed, it's having the hard conversations, but like really addressing the thing kind of that's kind of hard to qualify. And that is that there's certain interactions that, because you are who you are, you don't have the burden. So I will give an example that is very different. I am athletic and unfortunately middle-aged now and things are changing, but I've never had to worry about my weight. Like literally, I've never had to worry about my weight. I exercise, I'm active, I eat what I kind of want. I did. So my perspective on weight management is different than someone who has had to worry about their weight their whole life with every activity. I don't feel that. I don't understand it. And it could be very easy for me to have less empathy for it. And I just try to put it in a framework that's not about race or gender, because that seems to be so uncomfortable for people. But, you know, I have to check myself when someone is talking about weight things. I was like, just eat better and healthy and go move or something. But that's not it. It's kind of the same thinking with, okay, so these people have a certain asterisk or they're burdened in a different way. So just like she was saying, every interaction that a person from an underrepresented class has, there's so much thought and emotional exercise that goes with every interaction. How do I receive criticism? Okay, so if somebody I feel has treated me unfairly, how do I receive this criticism? Is it fair criticism? Is it unfair criticism? Are they right in spite of them still treating me like garbage? How do I fix it for them? Do I actually address it? Do I do that? Like, and my husband was like, I don't think about any of that. Like, none of my interactions involve all this complexity of thought. And I'm like, every interaction that I have in certain spaces is complex and it's emotionally burdensome. And it does take a hit. Your well-being can take a hit because it's really easy to point out, like in some populations, your flaws are really exposed more than your successes, or you're expected to achieve and everybody else, you know, can make a mistake. One of the jokes was in residency, you know, some of the guys could like make a mistake. Oh my God, you hit the radial nerve, and they joke. It's like it's a joke amongst all, like the whole thing, the whole group, and you know we call it, you know, doing so. They named a mistake after this resident, and I was like, if I made this mistake, I would be thrown out of residency. Like it's not. It certainly wouldn't have been funny, right? So it's having the hard conversation and it's bringing it to the attention of people that don't have to experience that, so they can maybe modify their thinking or maybe not. I don't know, because that's the hard part. The hard part is we have to have a root change in perception of what this is really about. So, you know, inclusivity, consideration for kind of past things. Everyone's path looks a little bit different, but I don't think I don't think that there's one right way to a path. Like this male metric for the award winner that I wanted, that metric wasn't fitting for that person who is definitely worth the award. And how do we fix that? And I don't have the answer to that. I think discussions like this are how we get to it.
All right, well, I think that's time. So thank you for joining us. Thank you, Dr. Brown, for being here.
Oh, yeah.
You're not making you're probably better than some places. Dr. Hudson did honestly my pleasure. And Dr. You know him? Community pediatrician. He's got a great thought all already. I'm glad we keep talking about the
I think for time, good for that. Yeah, the orthopedic surgeon.
Let me
I'm not. Thank you for chatting.